So the topic is about Colles fracture. Colles fracture is fracture of distal end of the radius. So before going into deep, let's know the normal anatomy of the forearm bones. This side is radius and this is ulna. Radius is towards the palm, the thumb, and ulna is towards the little finger. So normally radius is slightly tilted towards the medial side, that is towards the ulna, and also to the ventrally, that is the palmar aspect of the hand. So, and also one more point, radial styloid lies 1 centimeter distal to the ulnar styloid. So when we come again to the Colles fracture, it's a fracture of distal end of the radius. So at the cortico-cancellous junction, what is this cortico-cancellous junction? Basically at the junction between softer and harder bone. So there it occurs. So basically the mechanism is fallen on outstretched hand, and also it mostly occurs in osteoporotic women, like post-menopause osteoporotic women, it occurs there. Coming to the mechanism, so basically the Colles fracture occurs due to fallen and outstretched hand. So basically the fracture occurs near the distal end of the radius, as we talked about it. So this causes characteristic displacement. So to understand it in a very better way, we divide that into AP view and lateral view. So in AP view, there is proximal shift. Proximal shift ka matlab the distal end of the radius which is broken, it moves upwards towards the elbow. Next, coming to the radial shift, it moves towards the thumb side. So more radially shifts. And then radial tilt, this not only shifting, it also tilts towards the thumb side. This is radial tilt. We can also call this as lateral tilt. These are the AP view wala things. And next, coming to lateral view. Lateral view, there is dorsal shift and dorsal tilt. Dorsal shift means the distal fragment, it is moving backward. Normally we talked about, right, normally it faces towards the palmar side. Now it goes dorsally towards the backward. Next, dorsal tilt. This not only shifts backwards but also it tilts. So this produces dinner fork deformity. This is classic feature of this Colles fracture. So this is because the distal fragment not only goes dorsally and also it goes upward. So the wrist bulges backward. This is producing dinner fork deformity. So the clinical features. So basically we have pain, swelling and deformity of the wrist. So on examination we find there is a tenderness, irregularity and classic dinner fork deformity, as we have talked about it. And next is the proximal migration of the distal fragment. Proximal, we talked about, it is towards the elbow. So there is loss of the radial height. So radial height, when this is moving towards up, so there is loss of the radial height. So this comes at the level of the ulnar styloid process. This is what happens on examination, right? So coming to the diagnosis, first we see about the radiological features. Two things are there here, dorsal tilt and lateral tilt. Dorsal tilt can be best visualized on lateral x-ray and lateral tilt can be best visualized on AP x-ray. So dorsal tilt, normally radius faces towards palm, like ventral, we talked about it. So in Colles fracture, what happens? It faces dorsally, and whereas in lateral tilt, normally the distal end of the radius is slightly tilted towards the ulna, medially. We have talked all this. And the Colles fracture, it tilts towards the radius side. This is lateral tilt. So just remember these points of the x-ray. Normal radius, it tilts towards the palm and tilt towards the ulna. Colles fracture tilts towards the backwards and loses normal inward tilt. Iska matlab, medial tilt is lost and may become flat or sideways also. Now coming to the treatment, if it's an undisplaced fracture, first, so we will immobilize the wrist by applying the plaster cast below the elbow, and then we keep it for 6 weeks. So we don't do heavy treatment here, we just immobilize the wrist. And coming to the displaced fractures, first, we do closed reduction. First thing is we give anesthesia. We give anesthesia to relax the muscles of the forearm and also to manipulate the pain while performing the procedure. And we grasp the injured hands as a shaking hands position, and then we do the disimpaction of the fragments. So traction is done to disimpact the separate the impacted fragments. So traction and counter traction is there. So traction is applied to the hand, longitudinal traction is applied to the hand, and the counter traction is provided at the arm above the flexed elbow. And coming to the correction of the deformity, normally the fracture is, as we talked, it is towards the backward and laterally. So the reduction should be in the opposite side. So for backward, we do it forward by palmar flexion technique, and also for the laterally, we do it inward by ulnar deviation. And then we take an x-ray. If it's good, we apply the Colles cast, and then afterwards we do follow-up x-rays. Now let's see the operative treatment of Colles fracture. So operative treatment like surgery is needed mostly in the young patients and in the old persons where there is an intraarticular extension and in unstable fractures. The first method is plating. So in plating, it is reduced under direct vision. The surgeon opens the area and directly aligns the fragments. So metal plates and screws are used here to hold the bone in proper position. And percutaneous pinning, second technique. So here it is reduced under anesthesia under the X-ray control, image intensifier. So next it is fixed by thin steel wires, 2 mm steel wires, we also call it as K wires, percutaneously. Next thing is external fixation. External fixation, here pins are inserted into the bone and connected outside the body by a frame. The principle behind is ligamentotaxis. Here the external fixator keeps the fracture distracted so that the stretched ligaments helps to align the fragment. So the complications of Colles fracture. The most common complication is stiffness. So finger stiffness. This usually happens because of the prolonged immobilization, and this there may be elbow stiffness, wrist stiffness also, shoulder stiffness also. We advise to mobilize the joint while we apply the Colles cast. Next, malunion. Malunion is redisplacement of the fracture within the plaster. So this causes malunion. This again leads to dinner fork deformity. So because of the dinner fork deformity, there is decreased wrist movement and weak grip, and there is an ugly deformity. And coming to the carpal tunnel syndrome, basically the median nerve is compressed inside the carpal tunnel. So this is carpal tunnel syndrome. So the patient may complain of pain, numbness or tingling in the hand. Next one is Sudek's dystrophy, osteodystrophy. This is also called complex regional pain syndrome. Because of the nerve and autonomic disturbance, the patient develops pain, stiffness, swelling of the hand, and also the overlying skin is stretched and glossy. So the treatment here is intensive physiotherapy. Next one is subluxation of the inferior radioulnar joint. So the radius is shortened, the ulna becomes relatively prominent, so the joint alignment gets disturbed here. So as a result, ulnar deviation and forearm rotation is painful and restricted. The sixth complication is rupture of extensor pollicis longus tendon. So the patient cannot properly extend the thumb here.